Lo puse.
Entonces, hay que estudiar como preparar el examen y eso me molesta. No entiendo. María, tengo pastilla, quiero. Yo a ti te voy a cobrar, porque tú me estás gastando las cosas. ¿Cuánto está allá atrás? Bueno, pero boleto.
Ya por ahí estamos.
Mira, esta flecha en esta flecha.
Anda, voy a hacer para esta mañana.
Mira, tú sabes izquierda, pero por lo menos estar por media hora.
Y eso me lo digo ya como 10 días después de haberlo.
¿Ya? Lo puedo cobrar.
Yo traté de como que de promocionarlo por ahí, pero que no van a estar. Pero ellos van para ir, pero a la 1:30.
All right. I think, you know what? I think what will be a good idea is we'll get started with some of the basic stuff, get through the learning objectives, and hopefully some folks will filter in here as they're coming back from the healthcare expo over in Timonium. But hopefully all of you are doing well. It's good to see everybody again. And welcome to the final module in the fall semester. I can't believe we're already there, right? Yeah, I know. That's definitely a reason for applause and excitement. So Dr. Foles unfortunately couldn't be here to start with today because she's actually teaching the PA students upstairs. So she asked me to kind of get started, and frankly, most of today is going to be me. We're going to be going over, blood glucose regulation in the body. We're also going to be talking about some of the pathophysiologic processes associated with the different types of diabetes, diabetic disorders, primarily type 1 and type 2 that we're going to talk about. And then she'll come in towards the end of today and start talking about some of the clinical aspects of that and into tomorrow. Okay, so we will we'll do that. What I think we should do, and I'll talk to her very briefly, is that we'll go over the syllabus with you tomorrow. I'd like her to be here as well too as we go through it. I will tell you that there are, again, this is a 2-credit module, so there are 2 exams, a couple of case studies that you're going to be doing. We're going to continue that. That'll make up the bulk of your grade in this particular course. Also, just keep in mind today and tomorrow, class starts at 2:30 to 4:20. Okay, so just keep that in mind. Again, you guys are all familiar with the weekly schedule. It doesn't change from cardio or renal, but we just have a couple of things going on over the next 2 days that, necessitated a slight change in the class schedule. Okay? Any questions for me before we get started? Logistics questions? Are we good to go? All right. So, let's take a look. So we are diabetes, okay, and we're primarily talking about type 1 and type 2, and out of the 2 of those, our primary focus is going to be on type 2 diabetes. Okay, these are chronic medical conditions that require chronic treatment and management. We don't have any cures for either of those 2 disorders, but they have a significant impact, especially type 2 diabetes, on the general population in the United States and healthcare in general. It's a major disease state. No matter what area of practice you're in, you're going to run into patients with type 2 diabetes, okay? So this is like hypertension, like dyslipidemia. This is a real important topic to dive into and make sure you're knowledgeable about, okay? Not just from a NAPLEX standpoint, but definitely from a practice standpoint, okay? And Dr. Foles spends a lot of time, and I know, and I'll steal some of her thunder. She spends a ton of time working with patients with type 2 diabetes to try to get their blood sugar under control. So she's got a wealth of experience, practical experience on this, and I think you'll really enjoy her instruction on this. This is also an integrated lecture, okay? So we will be, Dr. Foles and I will be in the classroom every day, and we'll be kind of moving back and forth. So hopefully that, again, will help some of your understanding to see how the basic and clinical sciences are bridged here in this disease state, okay? 2 sets of learning objectives. So let's take a look at the learning objectives for this slide set 1. These are the science objectives, okay? So again, we're going to talk a lot about the physiologic regulation of blood glucose because essentially diabetes is a dysregulation of that process. It's the inability of the body to effectively manage or regulate blood glucose levels. And there are a variety of reasons for that, which we're going to get into in a bit. So you have to understand from a basic standpoint blood glucose regulation in order to understand the pathophysiologic processes. There are lots of hormones involved in blood glucose regulation, so it's going to be important for you to be familiar with them, okay? 2 of the big ones are going to be glucagon and insulin. All right, you probably talked about these in the biomedical sciences workshop or pathophysiology course that you took in your first year, okay? We're going to revisit that review because it's been 2 years since you've had that, so we want to make sure you're up to speed on that. Amylin and especially incretin is another important one. So everybody's heard about the GLP-1 agonists, right, that are out there that you probably see ads on social media for and all that good stuff. Again, they are based on actual hormones that your body produces that helps your body to regulate blood glucose levels. And so, again, we're going to explore what the incretin hormones are. I don't suspect you have those in your first year, so we're going to talk about what they are, where they're produced, how they work, and then we'll talk about the drugs that mimic their effects in a couple of days. Okay? We will talk just very briefly about the synthesis of insulin, okay, and how that happens. We'll talk about pancreatic beta cells, and you should be able to explain how pancreatic beta cells, which are specialized cells in the kidney, how they can detect changes in blood glucose levels and use that information to regulate insulin and glucagon secretion. Okay, because those are the hormones that primarily work to regulate blood glucose levels. Okay, so we're going to spend some time with our pancreatic beta cells and talk about how they work. We're going to talk about early and late phase insulin release. So we look at insulin release patterns from the pancreas, okay, and what that looks like and why that happens. Now, there's an initial after you eat a meal. Let's say many of you may have just come from eating lunch, right? So right now, your pancreas is pumping out a ton of insulin into your bloodstream to help your body take up that glucose in the food that you're digesting and store it and utilize it. So there's a pretty rapid spike of blood glucose level or blood insulin levels, and then there's a secondary, slower and a bit lower level of insulin release after that. We'll talk about why that happens. We're going to talk about the insulin receptor, okay, and how it functions and a variety of its signaling components, signal transduction components. So when you were in biochemistry in your first year, you learned about the insulin receptor because it's the classic example of an enzymatic receptor, or as some people refer to them as tyrosine kinase receptors, okay, which is one type of enzymatic receptor. So we're going to, again, some of this stuff will seem vaguely familiar to you, okay, as we get into it, but we're going to review it. And then also the signaling pathways inside the cells that respond to insulin, what happens biochemically and how that leads to an increase in uptake of blood glucose, okay? And then you're going to need to be able to list the effects of the insulin receptor activation in the 3 major target tissues in the body. So insulin is a hormone that has effects across the entire body. But when we look at kind of major categories of tissues, right, that respond to insulin and really are important in blood glucose regulation, we have to really look at the liver, we have to look at adipose tissue, and we have to look at muscle tissue. So you need to understand what the effects of insulin and glucagon are on those tissues. And I'm also going to tell you that they just don't have effects on blood glucose uptake. There's other effects that they have on amino acid and fat uptake and things like that. So we'll talk more about that. So a lot of different things, okay? Dr. Foles, these are her clinical objectives. I'm going to let her review these with you and kind of illustrate what the important concepts are, what's going on here. But again, there's a lot of them here. Ultimately, your goal is going to be, right, is to, can you develop a patient care plan and take care of a patient with, especially with type 2 diabetes. We'll also go through type 1 diabetes, but we're really focused on type 2 diabetes here, okay? Do you know what drugs to use? Do you know how to use them? Do you know the side effects? When to use them? Those sorts of things. So she's going to talk all about that, okay? Again, here are the guidelines. I'm going to let Dr. Foles go through this as well, too. The American Diabetes Association, or guidelines, that she goes to all the time. These are really important, okay, for general clinical practice, and she's going to pull those up and go through those with you. So the guidelines are going to be your friend here with regards to this, okay? Bless you, okay? Now, again, prevalence and incidence, this is really more epidemiology. Dr. Foles does go over this. I want you to take away at this point, before she comes in and goes through some of the details here, okay, is to understand the extensive nature of this disease, the prevalence of this disease across the U.S. population, okay? So over 10% of the population has an actual diabetes diagnosis, whether it's type, and you see there's differences between type 1, which is T1D there, that's type 1 diabetes versus type 2 diabetes. The vast majority of people with diabetes have type 2, okay? A much smaller subset has type 1 diabetes. This topic is near and dear to my heart because my son, who's now a sophomore in college, he goes over to Loyola, he's a type 1 diabetic. And so this is Dr. Colleen and I have been living with that disease since he was 5. So for, about 15 years now, we've dealt with that. But again, the focus is going to be more on type 2 because that's what you're going to run into. Here's another astounding, statement here that I think is really important. 40%, almost 40% of the U.S. population has a prediabetes diagnosis, okay? And, it's not just people that are, overweight or obese, right? Because we often think about that, okay? I've got a prediabetes diagnosis, okay? And I've had one for years, okay? So we're going to talk a little bit about, things that can go on environmentally and from a lifestyle standpoint that can cause that to happen. We also can talk a lot about the genetics involved in type 2 diabetes, okay? In both type 1 and type 2s, you're going to see there's a genetic component and there's an environmental component, but the importance of each of those is different between type 1 and type 2. We'll talk about that, okay? But the bottom line take-home point is lots of people either have a diabetes diagnosis or they've got a pre-disease state diagnosis, right? And they may develop into full-blown diabetes at some point. So again, with major costs to the healthcare. So Dr. Foles is going to talk all about this, but I think it's super important to stress that, okay? This is also Dr. Foles' slide as well, too. And again, just to get you oriented, she'll talk more about this. Diabetes mellitus is a group of disorders, okay, that all have in common the fact that they're disorders of blood glucose regulation. But the cause of each one of those is very different. The pathophysiology is very different. But they all have in common, again, that they're generally defined by an inability of the body to normally regulate blood glucose levels. Okay. Whether we're talking about diabetes mellitus, type 1 diabetes, type 2, gestational diabetes, diabetes caused by other, disorders and things like that. So Dr. Foles is going to talk about that. All right. So take-home message: there's lots of different types of diabetes, different pathophysiologic causes. Diabetes is a big disease state across the U.S. population. More and more people are getting it. and there's a ton of healthcare costs associated with that, and that's where you come in as pharmacists to help people manage this disease and use their drugs effectively, okay, and safely. Yes.
I would like to say something because I would have liked to know this before.
Yeah.
On like your case, there are, and I had no clue. I thought I had more time. I had pre-diabetes, and now I am diabetic. I haven't been diagnosed with more than two, more than 200, like multiple times.
So you got
So
some
I know I am at this point. I'm just need to go to the doctor. But what I it took a very short time until, but and I checked my blood glucose frequently. So I know that from the time that I started to fall into the pre-diabetes diagnosis until the time that I started, it was a couple of months. So like not for everybody is going to be that. I wish I would have known because I thought that I had a couple of years to get my act
because
together.
typically when we talk about the pathophysiology, the pathogenesis, the development of type 2 diabetes, it occurs over decades for a lot of people, right? And but there are a lot of different causes to it, genetic, causes or deficits that can lead to that. And it may be that you just have a genetic phenotype that leads to a very quick onset of that particular, type 2 diabetes. But yeah, typically when we think about onset of type 2 diabetes, you're absolutely right. We usually think about it as being long, drawn out, right? But again, that doesn't necessarily have to be the case. And I think it's a good question to ask Dr. Coles to see if she's seen things like that as well. Okay. All right. Any other questions? All right, outstanding. So let's talk about the physiological regulation of blood glucose. Now, to start with, I want to start with kind of a big picture perspective here. I don't want to get too much into the weeds just right yet, but I want you to have an overall perspective of what's going on with regards to blood glucose regulation. This slide here, I sort of like to think like this is your math equation, right, for blood pressure regulation, right? This slide kind of shows you from a macro perspective or high-level viewpoint what's going on, okay? So, in the center here, I've got a big red circle, which represents our circulatory system, and we've got glucose in there. And so what are the different factors that determine, at any given minute, what our blood glucose levels are? And when we think about that, we've got to think about, different factors that influence how much glucose is entering into the circulation, which you see on the left there, and then how quickly and how much glucose is being removed from the circulation. So we have input over here and output over here. And it's the combination of those two, right, that will, again, give us an idea of, what blood glucose levels are and why they are at a certain point, okay? So when we talk about factors that allow glucose to enter into the circulation, okay, there are a couple of major ones that I think you need to know, okay? And again, I'm not going to test you on this particular piece here, but it's it's important to have this framework so that you can build on it as we talk about the hormones and different things that are going to occur. So number one, we have food intake, right? The amount of food that you eat, the type of food that you eat. All right. Some food, okay, is more glycemic than others in terms of it causes your blood sugar to spike. Okay, so if you're having a New York strip steak, right? Sounds pretty good to me, right? Or, okay, a 20-ounce bottle of Mountain Dew. Okay? Yeah, both of those types of food are going to have very different effects on blood glucose levels. Okay? So food intake is super important. The rate of gastric emptying and intestinal absorption can also impact blood glucose levels. Okay? So believe it or not, there are hormones that regulate how quickly food is released from your stomach and into the intestinal tract. And that can have a huge impact on blood glucose levels. The faster food is released from the stomach and into the intestinal tract, the faster your blood glucose levels after a meal will go up. If you slow that process down, okay, you'll get a much slower rise in blood glucose, and it'll be the peak of that will be a lot lower. Okay, the rate of intestinal absorption, again, how quickly your enterocytes, those are your cells that line the intestinal tract, how quickly they absorb glucose from the food that you're actively digesting will determine or help to determine blood glucose levels. So that's really important. Okay. Now we get into two words here that can be very confusing. Now, I don't know about you. I can't speak for you, but I can speak for myself. When I first learned this, it was the terminology that just threw me off because everything sounded the same. Gluconeogenesis and glycolysis, right? And, right? I mean, I'm like, I don't know which one's which. And so I would totally get, confused. So if you find that you're doing the trick I figured out how to beat this is to break the word down into smaller pieces and understand what each of the components of the word means, right? Okay? So when we look at gluconeogenesis, what in the world does that mean, right? We know it has something to do with glucose, right? Gluco is glucose, right? Genesis, right? Beginning or to create, right? And neo means what? New. So creation of new glucose molecules. And this is a process that occurs in your body. Your body can use non-glycemic sources, okay, like amino acids and different substrates to make glucose molecules. This process is really important during times of fasting when you're not actively digesting food. Okay, so at nighttime it's really important, or if you're fasting, it's important because your body, if you're not taking in glucose, your body still needs it, right? And so it's got to have a way of getting it, so we can make it out of other substances, but it's not quite as easy as ingesting it. Okay, and then glycogenolysis. Here's another one of those words, right? Okay, now if I break this up, okay, I've got two words really here. Glycogen and lysis, okay? If you remember, glycogen is the storage form of glucose, okay, right, in your body. So in the liver and in muscle tissue, stores glycogen. It's a polymer of glucose, right? And your body can access that storage of glucose by breaking that polymer down into individual glucose monomers that get released into the bloodstream, okay? So glycogenolysis or glycogenolysis is just a breakdown of glycogen into glucose molecules. Everybody got that? So those are four major things that can help to increase the input of glucose into the circulatory system. Now we have removal here, okay? So tissue uptake. So once the glucose gets into the bloodstream, where does it go? What does it do? Why is it important? Okay? Well, we know glucose is an important source of energy for tissues and cells in the body, right? So tissues have to have the ability to take glucose out of the circulatory system and use it to make ATP, okay? So the ability of tissues to do that, the speed at which they can do that, and the amount of glucose that they can take out of the blood and internalize will greatly impact blood glucose levels, okay? And guess what? Hormone regulates tissue uptake. Anybody have any ideas? What hormone stimulates tissue uptake of glucose?
Insulin.
Insulin, very good. Insulin, right? Okay, so we'll leave it simple like that. So insulin is that primary hormone that does that, okay? If you have a deficit in insulin in your body, let's say your pancreas doesn't produce it or doesn't produce enough, that will impact tissue uptake. Okay, you can kind of see that, right? Right? Tissue utilization. So once that tissue takes up glucose, what does it do with it, right? Okay, so it can convert glucose to ATP. It can store it as glycogen. It can convert it to different substances, like triglycerides, so that it can be stored in fat tissue. So essentially, glucose, again, if it's not being used immediately for energy, it's being stored in different forms in the body for use later on. Yes, sir.
So,
Yeah, we're going to talk about the effects of insulin on potassium levels in the body. Yeah, we're gonna, yeah, definitely get now. That's a huge effective insulin as well too in terms of potassium shift, where it goes in the body. Okay, and what happens when we don't have enough of it, because the potassium levels, we're gonna get to that. Definitely very important, effective insulin. Okay. Tissue storage we talked about, and then renal excretion. Okay, so again, your kidneys, if you remember from the renal module, right? We just had it, right? What part of the nephron reabsorbs glucose? And when after it's filtered? Yeah, the proximal convoluted tubule. Anybody remember how much or what percentage of glucose it's filtered? Yeah, like most of it, right? Okay, big chunk of it. Now, the processes, the transport processes that allow the proximal convoluted tubule to reabsorb glucose can be saturated and overwhelmed, right? So if you have a situation where blood glucose, okay, gets above 180 milligrams per deciliter, that level of blood glucose is enough to overwhelm the proximal convoluted tubule. It'll still reabsorb a ton of glucose, but it won't be able to reabsorb all of that. And so where does it end up at? If it can't reabsorb all of it, it ends up in the urine, right? So again, I always tell the story every year when we suspected my son had type 1 diabetes, Mrs. Dr. Culhane took him to the pediatrician's office. I was teaching in cardio, I was teaching arrhythmias, I remember that, okay? And they stuck his finger and they did a glucose check, and it was really high, like 500 something. And he also, I think the first thing they did was actually take a urine sample, and he was positive for glucose in his urine. And so they checked his blood sugar, and it was really, really high. It was like 550, I think it was. Okay? And so again, that's because his blood sugar levels were so high, his kidney couldn't reabsorb all that glucose, and it was spilling out into the urine. So from a diagnostic standpoint, this is super important. Okay? Everybody got that? So again, it's the balance between these major mechanisms that will determine what blood glucose is at any given minute of the day in any particular person. Okay? All right. Now, yes?
Can you explain this tissue utilization and tissue storage again?
Pardon me?
Tissue utilization and tissue storage.
Yeah.
Can you explain it again?
Yeah, so tissue utilization and tissue storage are things that are closely linked together. And just from a very basic perspective, right? Glucose is a major form of energy, right? And so your tissues, like your liver or your fat tissue or your muscle tissue, can use it as a source of energy to make ATP. If it doesn't need it, right? If it's not, then it ends up converting it to a storage form. So either triglycerides or glycogen, depending on what tissues it's being stored, right? All right. So again, there's definitely a balance between utilization and between storage. Okay. Now this particular diagram is sort of like the MAP equation. Remember we did that, or even the heart failure flow diagram. Remember we had that, the pathophysiology flow diagram I had with all the drugs in place. Yeah, this is the same thing as those two things. So this is kind of show you the major drug classes. Some of them on here aren't used anymore but I still think it is definitely useful, okay, as a kind of a tool to really kind of see what's going on here. So if we start at the top here, okay, we have the GI tract, okay, where food that's ingested is digested and glucose is absorbed into the bloodstream. Okay. One of the things that's going on at this level that can really impact blood glucose levels is the rate of gastric emptying. Okay, how fast the stomach empties its contents into the small intestines. And guess what major class of hormones regulates that? GLP-1 hormones, right? Your incretin hormones. So that should give you a little bit of a peek into, we're going to be talking about GLP-1 analogs, right? And you should be able to right now predict one of their effects. They slow gastric emptying, okay? Right. Now, once there used to be a class of drugs that we use called alpha-glucosidase inhibitors. We don't use those anymore, but they were a class of drugs that would inhibit an enzyme in the small intestine that would break down polysaccharides into individual glucose units to be more readily absorbed. So we don't need to worry about that. You can cross that out. But as glucose enters into the bloodstream as it's being absorbed in the intestinal tract, okay, it can be transported to different tissues. And we see lots of different tissues here, or cells that make up different tissues, okay? And so we've got glucose here, okay, in some of these other tissues like the lungs, the heart, the kidneys, the brain, okay, that require large levels of glucose and metabolize that into ATP for energy sources. Again, if you think about what organ in the body do you think places the greatest demand for glucose or has the greatest demand for glucose? The brain, absolutely. Okay, followed by the heart. Okay, so they require constant energy, and the brain really sucks up a lot of the glucose that you're ingesting and using it for energy. Okay, over here we have a pancreatic beta cell. So the tissue represented here is the pancreas, and this is one cell type in the pancreas. Pancreatic beta cells have two major functions that I want you to remember. Number one, they detect changes in blood glucose levels. Okay? They detect changes in blood glucose levels, and they respond by secreting insulin or not, depending on what the situation is. Okay? So blood glucose detection and insulin production and secretion. That's what our beta cells do. Okay? And again, if you have a situation where blood glucose levels are abnormally high in the body, right, insulin can help to bring them back down. So we have a lot of drugs that interact with, or drug classes and drugs that interact with pancreatic beta cells to enhance insulin release into the bloodstream. Okay? And so again, you can see some of these over here. Okay? Things like sulfonylureas, the GLP-1 analogs, the DPP-4 inhibitors. Okay? Don't worry so much about diazoxide and the glutamides, but just these three here, sulfonylureas, GLP-1 analogs, and DPP-4 inhibitors, we're going to talk mostly about. Okay? They can all impact beta cells in the pancreas and change the insulin release patterns and amounts. Okay? All right. Let's go down here to the liver. Liver's hugely important organ for blood glucose regulation. You can see here that the liver is responsive to insulin. Insulin has to be present and interacting with insulin receptors on the liver for it to be able to take up glucose out of the bloodstream. Insulin essentially unlocks tissues and allows them to take up glucose. Okay? And you can see here, okay, that as the liver cell takes up glucose, represented by this tan sphere here, okay, it converts it to glycogen. So activation of the insulin receptor has two effects, major effects on liver cells or hepatocytes with regards to glucose handling. It stimulates glucose uptake, as you can see there in the picture, and it also stimulates storage of glucose as glycogen. So hugely important. Okay? Now, glucagon, okay, is the opposing hormone to insulin. They're physiologic antagonists. Insulin stimulates glucose uptake and storage in tissues. Glucagon stimulates the breakdown of storage forms of glucose and release of glucose into the bloodstream. Okay? And it does that by stimulating glycogen breakdown. Remember, glycogen is a polymer of glucose, breaks it down into glucose monomers, which are very quickly released into the bloodstream, which will bring blood sugar levels back up. Okay? Glucagon can also stimulate gluconeogenesis. This is really important while you're sleeping, okay, and not actively digesting food. And it can take non-glycemic molecules and convert them into glucose that can be released into the bloodstream. So that's really important, okay? Now, again, if you take a look, again, I'll go back to my example of my son as a type 1 diabetic. Okay, sometimes he goes hypoglycemic. His blood sugar drops very low. Sometimes it's 70, 60, 50, even 40 milligrams per deciliter, which is very dangerous. Okay, if he can't get that back up, he has to give himself an injection of a glucagon analog usually into his leg muscle. Okay, and what that does is that stimulates glycogen breakdown very quickly and release of glucose into the bloodstream to help quickly bring his blood sugar back up. So our body makes glucagon, and we have drug formulations of glucagon that we can use. Did you have a question?
Yeah, was gluconeogenesis part of, like, I don't know if it was a metabolic process that uses ketones to make energy, or is it another?
That's a different. That's
beta oxidation.
Yeah.
Okay.
So we'll talk about that a little bit later. Yeah, definitely good question. Yeah, you guys know quite a bit about this. That's really good. All right. So yes, please.
I would like to get back to the GLP-1. The GLP-1.
Yeah.
When you said gastric emptying,
Yeah.
is this emptying of the bowel, or is it
Emptying of the stomach.
into the
Blood.
water?
Yeah. So it's actual emptying of the contents that are being digested in your stomach, right?
Into the water.
Into the blood. Yeah.
So not the
We're not talking about the other end now.
Okay.
Okay? All right? In fact, what bad side effect have you guys heard about with regards to the GLP-1 agonists? Gastroparesis, right? That means that your gastric emptying slows down, or you can get gastric paralysis, right? That's bad, very bad, right? Okay. So again, if that helps you remember what GLP-1 does, or at least part of its effects, that's great. Okay. All right. Over here we have adipose cells. So very quickly, also an insulin-sensitive cell type in tissue, fat tissue. Okay. Insulin receptors are activated. Glucose is taken up and converted into triglycerides. Okay. And again, this is an insulin-dependent effect. An insulin-dependent effect. So in order for fat tissue to take up glucose and convert it to triglycerides, insulin needs to be present and the fat tissue needs to be sensitive to it. Okay? Now, there's also another receptor type that can stimulate glucose's conversion to triglycerides. Okay? And that would be our PPAR receptors. Okay? And we'll talk more about those because there's a class of drugs called the thiazolidinediones that activate our PPAR receptors, okay, and can help fat tissue convert glucose that's being absorbed into triglycerides, okay? And the faster that happens and the better that happens, the more glucose that can be taken up out of the bloodstream, okay? And then over here we have muscle tissue. Again, very simply, insulin here stimulates uptake of glucose and conversion to glycogen. So again, you can use this diagram to kind of see what the effects of insulin and other hormones are on blood glucose regulation and kind of see where a lot of the major drug classes actually work, okay? Do we have drug forms of insulin? Oh, yes, we do, right, Dr. Folds? We got a lot of them. And we're going to spend a lot of time talking about their structure, their pharmacokinetics, right, and their use in treatment of different types of diabetes, okay? All right. Speaking of which, let's talk about insulin. Before we get started, just want to go through some terminology that I'll be using over the next couple of slides so you're familiar with that, okay? We're going to talk about glucagon-like peptide 1, or GLP-1. 10 years ago when I taught this, nobody had ever heard of an incretin. None of our students had heard of GLP-1. Now it's all over the place. Everybody, people on the street talk about GLP-1 drugs. They don't even know what GLP-1 is, okay? So this is one of the hormones in a class of hormones called the incretins, okay? And when we take a look by, these hormones are actually produced by the small intestines, okay? So again, the small intestines have an endocrine function that you may not have known about. So as food is being actively absorbed and digested, your small intestines are producing and releasing GLP-1 into the bloodstream, okay? One of the major effects, okay, that GLP-1s have, in addition to slowing gastric emptying is to enhance glucose-dependent insulin release. All right? So as your small intestines are digesting food and absorbing glucose, and as glucose levels start to rise in the blood, your small intestines are going to release GLP-1 also into the blood. Okay? And as the pancreatic beta cells are detecting this increase in blood glucose and getting prepared to release insulin, GLP-1 will also act on those cells to supercharge and enhance insulin secretion over what it normally would be. So it's a hormone that really helps to enhance insulin secretion, but it only does that when blood glucose levels are rising or are elevated, okay? And we'll get into more detail on that later on. Glycogenesis. Okay, we talked about glycogenolysis, right, which is the breakdown of glycogen, but glycogenesis is simply the production of glycogen from glucose molecules, okay? This is a polymerization reaction. Multiple glucose molecules stuck together give us glycogen. And then we have lipogenesis. This is the process of converting acetyl-CoA, okay, to fatty acids and stimulating triglyceride formation, okay? So again, and this all starts with glucose, all right? So again, lipogenesis is another term we'll use, and insulin stimulates that, okay? All right, so this is the overview slide that shows you everything that insulin does that I want you to know, okay? And I'm going to break this down very quickly for you so you can kind of see what we're talking about, okay? The meat and potatoes here, okay, the things that are really, really important are these three boxes here. You can star those or highlight them, all right? If you don't remember anything from this slide, please remember these boxes and what insulin does to fat tissue, muscle tissue, and liver tissue, okay? All right, that's a minimum. We start up here at the top very quickly with ingestion of carbohydrates, right? And as the carbohydrates pass through the intestinal tract, they're broken down, they're absorbed into the bloodstream, and as that is happening, guess what hormone is getting released? GLP-1, okay? Now, as plasma glucose levels begins to increase here, okay, the pancreatic beta cells will detect that and respond to it by releasing insulin. And GLP-1 will also stimulate the pancreatic beta cells to get them to release even more insulin than they normally would, okay? So there's a nice synergy there between pancreatic beta function and GLP-1 hormones, okay? Now, pancreatic beta cells will release insulin, okay, into the bloodstream. These beta cells actually store insulin in secretory vesicles. I'll show you maybe a picture of that later on. And that insulin is stored in those secretory vesicles with amylin, another hormone. So they're co-released into the bloodstream, insulin and amylin together, okay? And together, all right, they have all of these different effects on the different target tissues. Insulin on adipose tissue, again, will stimulate glucose uptake, like I showed you in the previous slide. Increased fatty acid uptake, okay? Increased lipogenesis, okay? In liver tissue, down there at the bottom, increased glucose uptake, right? That glucose will be converted to glycogen via the process of glycogenesis. And you also can get lipogenesis or lipid formation in the liver as well, too. And that's an insulin-stimulated event. And then in muscle tissue, you've got an increase in glucose uptake and glycogenesis, okay? These two are kind of coupled together. But also, insulin can stimulate amino acid, an increase in amino acid uptake into muscle tissue. And it can also stimulate protein synthesis, okay? So if you ever go on Google Images and you do a search for historical pictures of diabetic patients, right? It'll show you pictures of, prior to the discovery of insulin, young children, right? Who had type 1 diabetes, and they are totally wasted away. I mean, they're fat and their muscle tissue is gone. because that insulin is so important in supporting those tissues and causing them to grow. Without it, those patients lose their fat and muscle tissue, okay? When I look at pictures of my son a couple of months before his diagnosis, I could tell. I didn't see it at the time, but I could tell when I compared it to pictures from the previous year. He had lost a lot of weight, 8 pounds for a 5-year-old was a lot of weight. You could tell how gone, his face was gone, he was thin, okay? And so again, that's because his body wasn't making insulin, and so those tissues were wasting away. Yes, sir.
So insulin is going to increase the amino acid uptake, right? But
Yep.
would amino acid stimulate the production of insulin? I believe it doesn't.
No, it doesn't. But again, so the point here is that insulin not only, the major substance that it stimulates the uptake of is glucose. Okay, but you can see that it will also impact fatty acid uptake and amino acid uptake into different tissues. So it's not just important for glucose regulation and metabolism, but other effects. Okay, so again, Dr. Foles is going to talk about dyslipidemia and things like that can happen in patients with diabetes, and that has a lot to do with, dysregulation of their insulin production, okay, and their inability to process things like fatty acids. Okay, does that make sense? Okay, so yeah, it's a lot more. We always think about insulin, with glucose, but there are a lot of other things that it does as well that are equally important. Okay, Thank you, Mallory?
Insulin and whatever.
Amylin, yep.
So it's been separated to keep the rules country.
Yeah, exactly.
Because glycogenesis is creating more glucose.
No, glycogenesis is the creation of more glycogen, which is the storage form of glucose. It's easy to get them confused. I used to get confused all the time too. Okay? So, again, these terms, glycogenesis, gluconeogenesis, right? Glycogenolysis, they all sound the same. So when you see one of those words, stop, slow down, break it down, and it'll help you to remember what that means, because it's super easy to get it mixed up. Okay? All right. Let's turn our attention to glucagon. The good news is if you understand what insulin does in the body, it's just the opposite with glucagon. Okay? And we'll take a break here. And you know what? Maybe this is a good time to take a break. Let's take 5 or 6 minutes. Go get some caffeine, walk around a little bit. It's a little warm in here, so maybe go out in the lobby. All right? And then we'll see you back in here in a few minutes, okay? Good place to stop.
Well, I ran out of time to do intricacies and insulin dosing, and I'm not sure how. I think I'm unsure how much in depth I should go with certain things. Yeah, I don't really know. We could spend forever talking about insulin dosing, but I don't really know. Prescribers, they don't know how to dose insulin, so I'm going over the intricacies of dosing and just make sure that you at least know what these classes are. I don't know. So that's how it went. Yeah. Or Tyler. Yeah. So I think it went fine. Yeah, I liked doing it too. So I felt good about it. More out there. We just didn't get a lot of time to practice. It's still dosing. But I think I knew in my heart of hearts that would be the case. Good. My parents are in town right now, so they're taking on a PTO. So I'm doing PTO in the morning and then coming and teaching in the afternoon. And so I do feel a little scattered. Yeah. But it's been nice. It's been a little bit. We blew cellulose insulation into the attic. My dad and I rented We jackhammered and took out a little part of the sidewalk so we can park our cars in the back. Yeah, they're very heavy. They're like 70 pounds. That's why I made it. Not that my dad's much bigger than I am, but he's better at it. He did the jackhammer, not I. Yeah, so right now I left them working on, I need to do some like concrete as like stepping stones. And the guy did some minor electrical work this morning. Yeah, they came up to do these
Oh,
things.
that's awesome. That is so
They're
nice
very
to
kind to me.
have. That is nice to have.
Yeah.
Yeah, this
Él venía de una adquisición como que
How about you? Nicole's out of town until Friday.
Yeah.
Your first license. It just started yesterday.
No, ahorita no para.
No, it sounds like it's pretty a hectic, tight schedule.
We're usually.
Yeah. She comes back Friday, you said? I heard she got to see her mom for her birthday, her sisters. Yeah.
Yo sé que yo la miré y yo dije, ¿tú eres una enfermera?
You're all by yourself? Oh.
Ella no, ella corre como
Yeah, that's what I was thinking. I think I'll just go over the schedule briefly at the beginning of class and talk about the expectations for the days free for their meeting. And then talk about how we look in the case study similar to the other modules. No, it was. We have a senior expert. Because I think we could have started class at 1:30, but I was like, we might as well do 2:30. Like, it's usually like a Wednesday schedule, but it's not flip-flopped. So I don't know.
It works good, so we'll see.
Is it recording too?
All right, 2-minute warning. 2-minute warning. 2-minute warning. So I'm looking at the timer, maybe 1-minute warning.
¿Sabes qué a veces yo pienso? Que mandaron genética como persona a veces aviones.
¿Tú crees?
Ese sería el colmo, ¿verdad? Bueno, estaban los pacientes de clase. ¿Tú lo viste? La señora me vio y me dio un abrazo.
De verdad. No sabía.
Lindo.
All right, I think we're going to get started. So let's continue our discussion as people start coming back in about glucagon. Okay, another major hormone involved in blood glucose regulation. If you know how insulin works, This is just the opposite, right? It's a little bit more nuanced than that, but for the purposes of what we're doing, that'll give you 95% of where you need to go, okay? In terms of some terminology that we'll use as we're talking about the effects of glucose on blood sugar regulation, we have lipolysis, which is breakdown of lipids, okay? So we're breaking down stored triglycerides into fatty acids that are released into the bloodstream that can be used for energy. Another term is glycogenolysis. Again, glycogen and lysis, so the breakdown of glycogen into glucose monomers and rapid release into the bloodstream. So glucagon is critically important for that. Then we have gluconeogenesis. Okay. Gluco meaning glucose, neo meaning new, and genesis meaning to create, right? The creation of new glucose molecules from non-glycogenic sources. So again, believe it or not, your body can make glucose out of things like amino acids, pyruvate, lactate, and glycerol. These are all substances that your body can, through different metabolic processes, convert into glucose. These things are very important. This process is very, very important during when you're sleeping at night and during fasting states. But when you're not actively taking in glucose, your body can make it, okay? Because it's an important energy source and for other things, okay? Now, again, this is your overview slide of glucagon. So again, you can see here, instead of ingesting food, up here we have fasting. We're starting with fasting. So again, that could be, sleeping throughout the night. We're not actively eating. Or if you fast for health or religious purposes, you can think about what's going on here. Okay. During fasting states, there's a decrease in glucose intake and absorption. That will ultimately lead to a decline or decrease in plasma glucose levels. Obviously, we're not taking it in. We're not going to have it. A different type of pancreatic cells, this time it's your alpha cells, okay, that will detect this and release glucagon into the bloodstream, okay, as a result. And what can happen is your body will respond by breaking down stored forms of glucose and releasing that into the bloodstream to help bring up blood glucose levels. So in fat tissue, we get an increase in lipolysis, a breakdown of triglycerides, okay, into fatty acids and glycerol. Glucagon, really no effect on muscle tissue that we're aware of, but the liver, there's a big effect there. Once that glucagon hits the liver, we're going to get breakdown of glycogen and release of glycogen into the bloodstream, okay, which will rapidly boost blood glucose levels. It also stimulates the process of gluconeogenesis. Again, the production of new glucose molecules from non-glycogenic sources, like, again, amino acids, pyruvate, lactate, glycerol. And then also, again, breaking down of lipids in the liver to release fatty acids into the bloodstream. So, again, a complex series of events that occurs in response to release of both insulin and glucagon, and the effects are just the opposite of one another, okay? All right, now we're going to talk about incretins, all right, and the role in blood glucose regulation. So we've talked about insulin, we've talked about glucagon, now we're going to talk about the incretins. These are hormones like your GLP-1 hormones that also participate in blood glucose regulation, okay? So one of the major ones is glucagon-like peptide 1, also known as GLP-1. This is, again, secreted at a low-level basal rate during fasting. Okay, so your intestines are constantly producing and releasing a low level of GLP-1, but when glucose is being actively absorbed, okay, GLP-1 levels start to go up, and there's an increase in release from the intestines into the bloodstream. Okay. The effects of GLP-1 on blood glucose regulation, there's a lot of different things that it does. We talked about enhancing glucose-dependent insulin secretion. So again, when high levels of GLP-1 are present in the body, that hormone can act on the pancreatic beta cells and get those cells to release more insulin than they normally would. So it's an enhancement. And that usually occurs when blood glucose levels are high. Okay? We know that it slows gastric emptying, and if you can't remember that very well, just think about gastroparesis as a side effect for our GLP-1 drugs. Okay. It helps to regulate food intake. Okay. So it suppresses your appetite. It makes you feel full and not hungry. Okay. Again, one of the effects of the drugs that you see. Okay. And also, it has been shown to promote beta cell health. All right, so it is a hormone that actually helps beta cells to remain healthy and functional, which can be a big problem in type 2 diabetes and type 1 diabetes. Okay, but for different reasons. Yes.
Is it like mediated by the immune cells, or the mechanism is like more complicated
For
the beta health?
The beta cell health. Yeah, so if you're thinking like in terms of type 1 diabetes, which is an autoimmune disease, this won't have any effect on beta cell health. But what it will do is, in type 2 diabetes, we're going to talk about how beta cells over a prolonged period of time can be overworked because they're hyper-secreting insulin and trying to keep up with elevated blood glucose levels, and they can eventually burn out and die. Okay, and so again, GLP-1 has been shown to preserve those cells. Okay, and we'll talk more about that in a little bit. But good question. So GLP-1 and the incretins in general, okay, have a lot of effects on the body that can help regulate blood glucose levels. Very complex hormones, but very interesting ones as well. Okay. Another type of incretin hormone is GIP. Okay. Again, closely related structurally to GLP-1. Okay. And again, it can help to hypersecrete or stimulates insulin secretion due to hyperosmolality in the duodenum. So as food that's being actively digested by the stomach is released in the duodenum, the osmolality of that space and area increases dramatically, as you would expect. And that's a signal and a stimulus for GIP-1 to do its thing and impacts insulin secretion just like its close cousin GLP-1. Okay? DPP-4 is another term we're going to talk about. That's an abbreviation for dipeptidyl peptidase. It's an enzyme. Okay? The number 4 just indicates the isoform of that enzyme. There are lots of different isoforms of DPP enzymes. And this one we're talking about is the number 4 isoform. And this enzyme here, what it does in the body is that it actively breaks down the incretins after they're released from the small intestine. Turns out these hormones have a pretty short half-life. They don't survive long in their natural forms released by the small intestine. They get broken down by these plasma enzymes very, very quickly. So when we start talking about drug forms of GLP-1, okay, their structure of those drugs are going to be modified in such a way that will make them resistant to breakdown by these enzymes. Okay, so that's just something to keep in mind. Naturally occurring incretins like GLP-1 and GIP-1 get broken down very quickly. They have short half-lives, plasma half-lives, because of these enzymes. The drug forms of these hormones have been modified to make them resistant to the effects of these enzymes and to increase their half-life. Does that make sense to everybody? And I'll show you that specific example when we get to those drugs, okay? Yes, George. Yep.
So the GLP-1.
Yep.
The side effect of weight loss, I'm assuming is that due to the decreased appetite from the gastroparesis?
Yep. Yeah, so again, a lot of that has to do with the effects on appetite suppression. The central nervous system affects that. Okay, but you have all those other things going on as well too. Kind of a slowing of gastric emptying. And again, that can cause nausea. Right, so one of the side effects, again, you all hear about when people start on GLP-1 drugs, and Dr. Foles will talk about this, they can experience pretty extreme nausea. That's due to the significant slowing of gastric emptying, okay? And you also get the insulin effects as well, too, and those sorts of things. But yeah, I imagine a lot of the weight loss is really due to that suppression of appetite and slowing of gastric emptying. Okay? Got it? Good question, yeah. everybody's curious about these drugs because, like I said, even 5 years ago, nobody knew anything about these hormones and drugs. And now, they're very, very popular. All right. So we take a look at this picture. There's a lot of stuff here. All this is kind of an overview, a different picture of what I just told you. If this is confusing to you, don't worry about it. Ignore it. All right? But again, what you see here is this picture generally describes and gives you an overview of the effects of the incretins on glucose homeostasis. So we start up here in the upper left-hand corner with ingestion of food. Okay, as food is being digested and absorbed, you get the release of incretins from the small intestines, as you can see here. Okay, and we have active GLP-1 and GIP circulating in the bloodstream. And again, remember, the naturally occurring forms of these hormones, short half-life, quickly broken down by our DPP-4 enzymes. Okay, the molecules that do survive, again, can act on the pancreas to enhance insulin release, okay? And also to decrease glucagon release from alpha cells. That's another effect of these drugs, okay? And ultimately what that leads to is a decrease of blood glucose. So these are great drugs to help lower blood glucose levels, right? Preserve pancreatic beta cell health, right? Help with weight loss. It's another effect of these particular drugs. So again, Dr. Foles is going to talk all about their clinical and therapeutic benefits later on. Yes.
GLP-1s and glucagon-like.
Pardon me?
GLP-1.
Yes.
Glucagon-like.
Mm-hmm.
And they're increasing the release of glucagon. Would that be some kind of antagonism?
Yeah, we'll get into that. There's incretin receptors on pancreatic beta cells, right, that are coupled to dental cyclase that will mediate a lot of these effects, and also on the alpha cells as well. So again, on the beta cells, activating the GLP-1 receptors, okay, stimulating an enhanced insulin secretion. And then over on the pancreatic alpha cells that produce and release glucagon, similar thing. We've got activation of GLP-1 receptors there, and there's a signaling pathway that's coupled to those receptors to ultimately suppress glucagon release. So yeah, it's kind of like you can almost think about it like a negative feedback loop almost for glucagon release. Again, what I want you to focus on is really the effects on insulin. I mean, it does have the effects on glucagon. But in terms of our discussion of the therapeutic effectiveness of these drugs, we're going to also look at the enhanced insulin secretion as a way of lowering blood glucose. Okay? So these hormones, their overall effect is to decrease blood glucose levels. And they do that in two ways. One, they stimulate the beta cells to make and release more insulin, right, to boost insulin levels, which will lower blood glucose. They also shut down glucagon release. Yep. They stimulate insulin. Yeah.
I was thinking that it would behave like glucagon.
Yeah. The nomenclature on that is, maybe a little bit deceptive because what I imagine happens when they discover these hormones. Okay, they started to sequence their amino acid sequence or determine what they saw similarities to glucagon, but it's not identical to glucagon. Okay, it probably shares some sequence homology with glucagon, but not 100%. Okay, and frankly, I don't know what the percentage is, but it might be easy enough to look up. Okay, all right. Again, this is the 104th birthday for the discovery of insulin. We should probably change that every year, Dr. Foles. We recently studied the 100th year celebration back in 1921. Okay, we have a group of very young researchers, minus one old guy like yours truly, okay, that were Canadian researchers that actually were able to isolate and determine what hormone from the pancreas was involved in blood sugar regulation. And this was the discovery of insulin. And we have Frederick Banting, J.J.R. McLeod, Charles Best, and James Cullen. All four of them received the Nobel Prize for this discovery and transformed the treatment of diabetes. Prior to this discovery in 1921, if if you are a young child and you had type 1 diabetes, it was a terminal disease. You would die. Okay. So I always like to acknowledge these guys because if they hadn't done this, my son would be alive today. So I owe them a debt of gratitude for the work that they did. Okay. At any rate, and what I want you to all know is that they're all about your age, except for McLeod over here. Okay, they're all your age. They made one of the greatest discoveries, medical discoveries of the 20th century, and they were young like you are. So anything's possible, right? Even passing endocrine, right? Okay? All right.
And they didn't have AI.
And they didn't have AI. You're right. Okay, so hang in there. All right, good. All right. So insulin biochemistry. This is one of our learning objectives, just to talk a little bit about insulin biochemistry and synthesis. We're going to move through this because it's important, but not critically important. When we take a look at how insulin is produced in the body, it starts its life as proinsulin, actually pre-proinsulin, but we have proinsulin, which is a form of insulin here that shares some significant structural features to the active form of insulin over here. Okay, so insulin in its active form has an A chain and a B chain that are connected via 2 disulfide bonds. Okay, and this is the active form of insulin. When you go over here to proinsulin, this is actually the storage form of insulin. You can see here's the A chain, here's the B chain. They're still connected by 2 disulfide bonds, but there is a connecting peptide, okay, that connects the 2 chains, okay? When proinsulin is packaged into secretory vesicles, okay, in the secretory vesicles, in the pancreatic beta cells, there are proteolytic enzymes that cut off the connecting peptide. And so when insulin is released into the bloodstream, not only is it released in the bloodstream, but amylin is, as well as the connecting peptide, otherwise known as C-peptide. And C-peptide is a marker, a biochemical marker for insulin production and release. Okay? So one of the things that they did with my son when he was first diagnosed with type 1 diabetes was to take a blood sample and see if there was any C-peptide in his blood. Okay? And if there wasn't, then his pancreas wasn't making and releasing any insulin. And there wasn't. Okay? So C-peptide is a marker for insulin release, which is why I talk about this. Okay? In terms of storage and release, and this is really important to talk about because later on we're going to talk about manufactured forms of insulin and how it's formulated and how that impacts the speed at which the insulin is released after it's injected, okay? And it's related directly to this slide here, okay? So when insulin is produced in pancreatic beta cells, it is packaged inside secretory vesicles, and it sits there until it's needed and released into the bloodstream to help regulate blood glucose, okay? But the way that it's packaged is really, really interesting, okay? So you can see here that insulin is packaged as individual crystalline units, all right? The stars here represent individual insulin molecules, and the red circles represent zinc cations. So as the pancreas makes insulin and packages it into the secretory vesicles, it stores it in there with zinc cations, which facilitates the formation of these hexameric crystals, okay? And you can see then how all of these crystals fit really nicely, neatly, and efficiently into that secretory vesicle. It's sort of like when you go get ready to go on vacation, right? And you're packing your suitcase. You take all your clothes, right? And you fold them neatly, right, on top of one another, and you stuff that suitcase full, right, with nicely folded and packaged clothing, right? But when you come home and you've worn all your clothes, what do you do with them? You stuff them into the suitcase, right? Well, at least I do, right? And guess what? You can't get your suitcase closed because your clothes aren't folded and packaged nicely and neatly. So again, just like this, insulin is packaged nicely and neatly into these secretory vesicles so that lots of these molecules can be stored in that way. Yes?
Is is it packaged with the zinc bank molecules and in a hexamer?
Yeah.
In the body.
In the body, yeah. This is what happens in the body, right? And then when the insulin crystals here that I have shown up are released into the bloodstream, it takes a little bit of time for those hexameric crystals to break down and the insulin molecules to break off of the zinc, and they can actually have an effect on target tissues. All right? So this is really important not only for storage, but also for the natural pharmacokinetics of naturally produced insulin. Okay? Because when these secretory vesicles fuse with the cell membranes of our beta cells and are released into the bloodstream, individual insulin molecules aren't released. It's these crystals of insulin formed around two zinc cations. And it takes a while for those complexes to break down. They're fairly stable. But in order for insulin to solubilize in the blood and also to have its effect on insulin receptors, these hexameric complexes need to break down. Okay? Now, there is an amino acid, okay, on the insulin molecule that is critical for the formation of these crystalline structures here. And that is the proline at position 28 on the V chain. So I go back here, okay, and I'll show you pictures of this later on. It's this amino acid residue right here, this little circle. That's the proline at position 28, okay? And again, that's what helps to facilitate these crystalline structures. If you change that amino acid or modify it in any way, guess what happens? The crystals don't form. They're very unstable, okay? And so we'll talk more about how, again, we can utilize our knowledge of how insulin's naturally packaged and released to develop genetically engineered insulins that have different pharmacokinetic profiles, okay? All right. So storage and release of insulin, and this is really important because some of our drug classes actually work on this process, so you need to understand this, okay? So what I have here is the process listed out step by step, what happens one thing after the other, okay? And then over here I have a cartoon picture that shows you what exactly is going on, all right? So the first step is increase in postprandial blood glucose. Postprandial is a fancy word for post-meal, okay? Post-meal blood glucose increases. So you eat, your blood glucose levels go up. The blue circles here represent glucose molecules. Okay, and they are transported, okay, into the beta cell by this glucose transporter called GLUT4. GLUT stands for glucose transporter, or GLUT, okay? And so, again, 1 and 2 are occurring here, all right? Now, as more glucose is taken up into the beta cell, which you see right here in the pancreas, glycolysis begins to increase. And glycolysis, as you remember, is the conversion of glucose into ATP molecules. And these little star-like molecules here are supposed to represent ATP. Okay? So we have step 3 here, increase in ATP production. Now, as ATP levels increase inside the pancreatic beta cell due to increase in blood glucose and uptake, that ATP will stimulate the closure of a potassium channel right here. That is your ATP-sensitive potassium channel. That's step 4, okay? And if that potassium channel closes, potassium builds up inside the cell. And what charge does potassium have? Positive or negative? Positive, right? And that buildup of positively charged potassium ions will lead to a membrane depolarization, okay? And that is step 5, okay? That membrane depolarization will then lead to the opening of a voltage-gated calcium channel here, allowing for calcium ions to rush into the pancreatic beta cell, okay? That is step 6. And then that calcium will stimulate the fusion of insulin-containing vesicles, okay, with the cell membrane here, and release of insulin into the extracellular fluid, okay? And not only is insulin released, but zinc cations, represented by these blue ovals here, okay, as well as amylin and C-peptide. So a lot being released from these vesicles, okay? So again, okay, and Kingsley, just to address one of your questions earlier about GLP-1, okay? You see this receptor right here? That's a GLP-1 receptor, okay? We're going to talk more about the effects of GLP-1 on this receptor right here. And this is adenyl cyclase, okay? So we'll talk more about the effects of it on that later on, okay? So again, step by step here, this is how pancreatic beta cells detect changes in blood glucose levels and how that can stimulate these cells to release insulin. It's a complex process. But the reason I go through it is because there are drugs that can bypass some of these steps and directly lead to insulin release, okay, by using some of these mechanisms here, okay? What questions do you have about this? Anything that you're confused about? Because usually this is a point of confusion for everybody, just simply because there's a lot of different steps. Everybody good? All right. Fantastic. All right. All right. One of the learning objectives that we talked about at the beginning of class today was talking about early and late phase insulin release patterns. Okay, and so when you're digesting a food and absorbing glucose into the bloodstream, insulin release occurs as a result of that, and there's a biphasic release, two different phases, okay, of release of insulin. We have the early phase of insulin release, okay, which is also referred to as primary secretion. And in early phase insulin release, okay, it occurs very rapidly, minutes after food is being digested and glucose is being absorbed. This insulin helps the body get a little bit ahead of itself so that you don't get massive spikes in blood glucose levels, okay? Insulin levels during this early phase will peak in about 10 minutes, okay? And then, and it comes down fairly quickly after that. Most of the insulin that's released during the early phase of insulin secretion is insulin that's been produced already and stored in secretory vesicles, okay? So it's all of this insulin right here that's stored in secretory vesicles and is waiting to be deployed, okay? So you had lunch today, maybe you stopped at McDonald's over in Timonium, right? And got yourself a soda, a Big Mac, or cheeseburgers or whatever. You're starting to eat that, and as you're eating it and digesting it, early phase insulin release is occurring. Your pancreas is releasing a lot of insulin very rapidly. You get a spike in about 10 minutes of insulin levels, and that helps your body to start dealing with the rapid increase in glucose it's going to experience as your body's absorbing the glucose from your McDonald's meal, okay? Or Chick-fil-A, or whatever you had to eat on the way over here, okay? All right. Late phase, or secondary secretion, occurs much later, okay? So anywhere from 10 to 60 minutes. You'll see here that there's a much slower rise in insulin levels in the secondary phase, okay? And the reason for this is because the insulin that's released from pancreatic beta cells in this phase of insulin secretion is insulin that's actually being produced at the same time. It's not stored insulin, it's insulin that's being produced and released, all right? So newly synthesized insulin is what you see there, okay? So if we take a look at this picture here that shows insulin secretory patterns, okay, across a 24-hour period here, okay? And I just want you to look at the blue line for right now. So if we take a look at this graph here, we have time on the x-axis starting at 7 a.m. and going all the way through 7 a.m. the next morning, so a 24-hour period, okay? We're looking at the blue line here, right here. At 8, we're having breakfast, okay? Well, look what happens. You eat breakfast, and as you're digesting that food, what happens to your insulin levels? And they increase really rapidly. They spike, right? And then they very quickly go down. That's that initial insulin release, that early phase insulin release. That's release of all that insulin that's been stored in the beta cells and vesicles. It's just getting dumped out into the bloodstream. Okay? Then you can see it comes back down. All right? And then we get a second peak here. All right? This is that secondary release. And again, you can see it's much slower, much lower. Okay? And this is release of insulin, newly synthesized insulin that the pancreatic beta cells are making as they're releasing it. Okay? So there's your primary, secondary secretion. You can see the same pattern after lunch, right? Primary spike here, secondary spike here, and the same thing after dinner. Okay? So again, that's kind of the naturally occurring way that insulin is released from the pancreas. Now the challenge is, especially in patients that are insulin deficient, like type 1 diabetics, is can we mimic as closely as possible that secretory pattern, right? Because that's what your body does. It turns out it's very, very difficult to do, okay? All right? We've gotten better at it with technology, but it's very difficult to mimic that exactly, all right? You can also see on here, the red line shows how blood glucose levels closely follows the spiking of insulin, right, and the reduction of insulin, okay? And so, again, what you really should just kind of look at here is the blue and red lines. Okay? Yes, sir?
So, how it's going to look like in patients that are doing keto diet? Like, how it's going to reflect on this?
Yeah, so that's going to be a little bit different. I mean, there's still primary and secondary secretion, okay? Because remember, insulin is important for digestion and tissue uptake of amino acids and fatty acids, okay? I would imagine that the amount of insulin that's being released is less, all right? But I suspect you're probably still going to see a similar type of pattern. It's a good question. And again, I'm theorizing because I've never seen a graph of that.
They are not taking it.
They're not taking in any glucose, right? And glucose is a primary stimulus for insulin release, okay? But there are other things that will cause its release as well, too, okay? And the other thing that you have to keep in mind is, with insulin release, we're not going from zero insulin to a spike, right? There's always a basal level of insulin that is present throughout the day. Your pancreas is always releasing insulin at a low level, even if there's no food on board. So that can also help to process amino acids and fatty acids and things like that. People that are doing like the keto diet, right? They're not eating any carbs, right? But you still need insulin to process amino acids and fatty acids and stuff like that. So it could be that low level of basal insulin production covers that. But you're not seeing the big spikes that you would when you're taking glucose. Does that make sense? Okay, so the patterns are going to look different, all right? What's that, Casey?
If I have enough insulin theoretically to deal with my glucose and breakfast,
Yeah.
I still get a secondary secretion. Because it seems to be the secondary secretion is coming because the first one is used up. And then I still need insulin, and so the body has to take the manufacture to get the second peak. So if I have enough, maybe I need just to vary to glucose.
Yeah.
It's enough to take care of the glucose I have. But this still needs to form a second.
Yeah, so I think a lot of it has to do with the speed at which the food is released from the stomach and into the intestine and how long it takes to be absorbed. That takes some time. You take a couple of hours after you eat for that food to get digested and fully absorbed, right? And the half-life of insulin in the body is fairly quick. All right, so it'll be gone in that initial insulin that's produced. You can see here, as it peaks. Yeah, it's 30 minutes or so to it, it's gone. So the body is continually releasing insulin to deal with all the food as it's being absorbed and digested over a several-hour period. all right? And that big spike at the beginning is to do kind of what you're talking about, to really prevent huge spike in blood glucose, to get it down quickly to manageable levels, and then the pancreas can keep up with that by synthesizing new insulin and releasing it. Does that make sense? So yeah, it's really interesting to see how complex the release patterns are, right? Okay, and like I said, it's very hard to mimic this with exogenous insulins or technology. All right. Very quickly, insulin receptor pharmacology. Okay, so again, the insulin receptor is an enzymatic or tyrosine kinase-like receptor. You learned about these in biochemistry 2 years ago. Okay, and in fact, I think Leninger, it uses the insulin receptor as its primary example of this. Okay, general function of the insulin receptor is it participates in glucose homeostasis. Okay, so it helps the body regulate glucose. This is a picture of the insulin receptor itself. Okay, kind of a cartoon picture. It's got a lot of different domains. Okay, and I'm not going to test you on this, but again, what you should basically remember here is just we have a hormone binding domain. This is where the insulin right here binds to the receptor and activates it. The alpha subunit of the receptor is responsible for that. And then we have a beta subunit of the receptor that is made up by the transmembrane region. That's the region that runs through the cell membrane. And also the enzymatic region, okay, of the receptor itself. And the enzymatic function of this region is that it's a tyrosine kinase. So what the insulin receptor does when it's activated is that it phosphorylates tyrosine residues on signaling proteins that work with the receptor to transmit the signal into the cell that's carried by insulin, okay? There is autophosphorylation of the receptor that occurs, so the receptor can phosphorylate itself. Okay. There are a number of tyrosine residues. Okay, I only show it on this side of the receptor, but they're present here. That the enzymatic region of the receptor can stick phosphate groups onto itself to prolong its activation, but it can also phosphorylate signaling proteins that will dock with and interact with the receptor, which I'll show you in a minute, okay? So again, the take-home message here from this you really need to know, okay, is that the insulin receptor is an enzymatic receptor, okay? More specifically, it's a tyrosine kinase receptor because that's what its enzymatic function is. It's activated by insulin, okay? And when the receptor is activated, it turns on this enzymatic region here, and that part of the receptor will begin to phosphorylate itself as well as signaling proteins that interact with the receptor. Don't worry about the different regions or domains here, okay? Or any of these tyrosine residues here, okay? I don't need you to learn those. I just want you to know the basics of the receptor, okay? All right. So, for a long time, we didn't really understand how insulin receptors, when they were activated, stimulated glucose uptake. And I had other effects in body tissues. But we know a lot more about that now than we did years ago. Okay? And this is a, yes, simplified diagram. Okay? It's way more complicated than this, but this is a simplified diagram of the signal transduction pathways, plural, that are activated by an active insulin receptor, okay? So to get everybody oriented here, and again, you may have learned about this in biochemistry, I don't know what you were taught specifically, but here we have an insulin receptor that's been activated by an insulin molecule, okay? And that leads to the activation of the tyrosine kinase region of the receptor. And when that enzymatic region is turned on, it begins to stick phosphate groups onto tyrosine residues. So again, you can see, look at all the phosphate groups here, 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 that have been stuck onto the receptor itself. And those phosphate groups prolong receptor activation, but they also have another important function. Okay? They serve as docking sites for signaling proteins that are inside the cell. All right? So, for example, okay, just as an example, you don't need to know this, but tyrosine at position 972 on the insulin receptor, when it's phosphorylated, that phosphate group serves as a docking site for insulin receptor substrate 1. It allows that protein to bind right to the receptor. Okay? IRS2 can bind to phosphate groups that are attached to the C-terminal amino acid, okay, right here. Okay? And as those signaling proteins are brought close to the receptor can add phosphate groups to them. So look at all. IRS1 has 3 phosphate groups attached to it by this receptor. And that allows for it to interact with PI3 kinase. And this protein complex here has a couple of major effects. Number 1, it stimulates the cells to insert glucose transporters into the cell membrane and allow target cells to take up glucose. Okay? So again, this is responsible right here for the glucose uptake effects of the insulin receptor. Okay? So glucose transport and glycogen synthesis, all regulated by the IRS1 PI3 kinase signaling pathway. Okay? Protein synthesis is also caused by IRS1 PI3 kinase. And mitogenesis, okay, growth of cells, okay, is also stimulated by insulin receptor activation. Okay, this is a growth hormone, right? Over here, we have a second signaling pathway that's activated by the insulin receptor. That's SHC, GREB2, and SOS. Okay? This complex is formed as these proteins interact with the insulin receptor, and the formation of this complex here can stimulate mitogenesis. Okay? So there's a lot of stuff that goes on when the insulin receptor is activated. But major ones include, as you saw earlier, glucose transport, glycogen synthesis, amino acid uptake, fatty acid uptake, and lipid synthesis. You know, all those good things can occur depending on what tissue we're talking about where the insulin receptor is activated. So a lot of stuff going on over here. We have some abbreviation and abbreviation key over here. So in case you're curious, you know, what TM stands for, it stands for the transmembrane domain. ECD, okay, is the extracellular domain, those sorts of things, okay? IRS is insulin receptor substrate, so just in case you get those confused. Bottom line is the insulin receptor, when it's activated, can activate multiple signal transduction pathways that lead to multiple biochemical/biological responses. A lot of them have to do with glucose uptake and glycogen synthesis, but it can also stimulate mitogenesis, protein synthesis, and other things like that, okay? And this table here is a summary table, so you don't have to create it, okay, of insulin effects on target tissue. So this is a good one to study from. You can empty it out and try to fill it back in again, but these are the different tissue effects that insulin has, you know, in the liver, adipose, and skeletal muscle. And again, I've already gone through these, so you can, you know, it's just there for you to study. Okay? All right. Pathophysiology of type 1 diabetes. Okay, we've got about 5 minutes left, 5 to 7 minutes. So I think we're gonna get into this because we started a little bit later. Okay, and then we'll finish it up later on. Let's start with type 1 diabetes. We'll go through that fairly quickly because we're not going to focus so much on that. But type 1 diabetes, like I said at the beginning of the lecture, it's an autoimmune disorder that has both genetic components to it and environmental components to it. All right? So there's different things that can lead to the development of that disease state in patients. Okay? we believe, what we know about it is that we think that there are a cluster of genes that patients inherit from their parents that can make them more susceptible for developing autoimmune disorders in general. And they end up, because of environmental exposure to different antigens or viruses, that they can develop type 1 diabetes, okay? The genetic component associated with type 1 diabetes is much weaker and less than the genetic component associated with type 2 diabetes. Type 2 diabetes has a much stronger genetic component than type 1 diabetes does, okay? The environment tends to play a bigger role in that than the genetic component. We still don't know what the environmental antigens are that a patient is exposed to. Like, I don't know why my son has type 1 diabetes. He obviously has this cluster of genes that make him susceptible to autoimmune diseases, but I don't know what caused it. Neither does Mrs. Dr. Colleen. You know, again, there's some theories that bovine insulin and cow milk can cause it in patients. Gluten or other types of cereal-derived proteins, different types of viruses, okay, that children can get when they're young, okay? All of those can hyperstimulate the immune system and cause the immune system to begin to attack the pancreas and the beta cells of the pancreas, which is what happens in type 1 diabetes, okay? So enteroviruses are implicated in this. We're not really sure yet what that is, okay? But whatever it is, a combination of genes and environmental exposure, it leads to hyperactivation of the immune system, and the immune system begins to attack the pancreas, specifically the cells in the pancreas that make insulin, which are your beta cells, and over a very rapid period of time, the immune system kills off all the beta cells in the pancreas, and the pancreas no longer makes insulin, okay? Again, the symptoms of type 1 diabetes don't typically start showing up until about 80% of the beta cells are destroyed in the pancreas by the immune system. So, you know, by the time my son was experiencing some of the classic symptoms of type 1 diabetes, the vast majority of his pancreatic beta cells had been destroyed by his immune system, okay? At least 80%. And the other 20% don't last much longer, okay? So some of the physiologic consequences that can also cause some of the signs and symptoms of type 1 diabetes, the number one thing is hyperglycemia, right? If your body doesn't make insulin, right, your blood glucose levels are going to skyrocket, right? Because your tissues need insulin to take glucose up. So hyperglycemia is one of the big consequences of that, okay? Now, we have the 3 Ps, I like to call them, of insulin. We have polyphagia, okay, which, you know, is referred to as is a fancy word for excessive hunger, or as I have it up there, hunger, okay? You know, Dr. Foltz, I've had that you know, for years, and I'm just going to leave it like that. I think after all these years, I'm just going to leave it as hunger, okay? But hunger, okay? So you're hungry, and why do you think a patient would be hungry if they're not making any insulin?
Because they cannot uptake glucose.
Yeah, their body can't use glucose or amino acids or even fatty acids, right? So the body essentially is starving. Even though you've got a lot of that stuff in the blood, the tissues can't take it up, okay? How about polyuria, excessive urination? Why do you think patients with type 1 diabetes that haven't been diagnosed yet are urinating excessively?
Because like glucose is a polar molecule and it's attracting water.
Yeah, and where does it end up in? When your blood glucose levels get really, really high, in the kidney and in the urine, right? So it ends up in the tubule, and that attracts water, you know, out of the extracellular fluid, and you get an increase in urine production. So that's how we caught it my son, okay? He was waking up in the middle of the night to urinate, and he never did that before. He even went to bed 1 or 2 times, and he never did that before either. And that was kind of the suspicion that led us to that symptom, okay? Led us to believe that he might have an issue. And then polydipsia, excessive thirst, right? Why? What's going on with your blood osmolality?
Excessive urine.
It's
Water to replace it.
Right, so again, you have excessive urine production, right? So you're going to be dehydrated. Your blood osmolality is going to go up, right? And that's going to stimulate thirst perception, and it's going to make you feel thirsty. So excessive drinking, okay, is also, something you'll see a lot. Weight loss, muscle and fat wasting, right? Because insulin's a growth hormone, and without it, muscle tissue can't take up amino acids and make protein. Adipose tissue can't take up fatty acids and make triglycerides. All right. So again, you get muscle and fat wasting. All right.
So your own body uses the muscle and fat to produce energy.
Exactly. So that's the other thing too, right? If your body can't use glucose for energy as an energy source, and it's the primary energy source, right? If that's gone, it's going to revert to secondary and tertiary energy sources like, which will be converted to ketones. So, fatty acids and amino acids. All right, to try to power itself, but it's kind of a losing battle. Okay.
Right.
Yes.
If the patient already has so much glucose in the system,
Yep.
and is feeling hungry,
Yeah.
and it takes that food,
Yeah.
what uses it?
Nothing. It continues to accumulate in the blood. Okay, so blood glucose levels get higher. Now your kidneys can get rid of some of that. Okay, but that's the problem, right?
So why does it feel hungry?
What's that? Because your tissues can't take up any of those nutrients. So your tissues are starving essentially. Okay, it's really weird.
Yeah, sometimes because it's like the abundance of water.
Yeah.
And you're thirsty.
Yeah. It's your body is essentially starving because it can't utilize any of those nutrients. None of the glucose, none of the fatty acids, or the amino acids, because there's no insulin for the tissues to take it up, so your body begins to starve, and that's why you're hungry. Okay, there are other things as your tissues start to waste away, you lose weight, you lose muscle mass, you start feeling very hungry, you're trying to eat to preserve that tissue mass. It's a vicious cycle. And unless you catch it, it can be very bad, okay? Diabetic ketoacidosis, we'll talk more about that tomorrow, and hyperkalemia, okay? That's a huge issue upon diagnosis of type 1 diabetics, okay? Is that one of the first things they check is your blood pH and your potassium levels. Those are the first thing they check when my son went into the pediatric intensive care unit, all right? Luckily, both of them were fairly good. All right, which was good for him, but some kids come in and they're really, really sick. And it takes weeks to get their blood pH and potassium levels regulated before they can, get out of the hospital. We were lucky. Okay? All right, it's 4:20 now. I think we're done for the day. All right. So again, take a look at this stuff. We'll be back tomorrow with more exciting diabetes news, okay?
At the same time.
At the same time.
And that's a little confusing.
So we'll be here tomorrow at 2:30. All right, just for this week because of stuff that's going on, and then we'll revert back to the normal weekly schedule next week. Okay. And by the way, thank Dr. Foles because we've got all of our Fridays, right? Most of them.
Most of them.
I think there's one. We'll get to the schedule tomorrow, but if you look at the schedule, most Fridays are either remediation or we're not having class that day. All right. So yeah. All right. I knew you'd be happy about that. All right.
I know we're gonna talk about this.